Hello.
Hi, how are you?
So you now understand that we are moving towards the absolute highlight of this conference. I'm very glad that Professor Mark Pimentel is with us. I would like to pass the mic to Professor Triantafylou to present him and present his CV, and also to present the speaker for this late afternoon.
So good evening. It's a great pleasure to introduce Professor Mark Pimentel. Professor Mark Pimentel is Executive Director, Medical Associated Science and Technology Program at Cedars-Sinai Medical Centers in Los Angeles, California. He's a well-known researcher, investigator, and a doctor who has assisted us in deep understanding the pathophysiology of irritable bowel syndrome. So he's the person who had in early 2000 thought out of the box, completely out of the box. And not only he thought out of the box, but he thrown the box out quite a way. And he introduced the knowledge that irritable bowel disease, it's an organic disease. It's not something that's coming out in my mind. And I was privileged to work with him and still continue to work with him. And we're looking forward to his presentation of the future direction of the treatment of irritable bowel disease. Dear Mark, please proceed. Thank you very much for being with us.
Thank you so much, and it's always a pleasure to see both of you, Evangelos and Kostas, and also the Greek colleagues who I've gotten to know over the years. So I'm going to share my screen. Hopefully you will see my slides. Do you see my slides?
Yes, we do.
Okay, so thank you. I have 25 minutes to cover a fair bit of ground. The future of treatment of irritable bowel syndrome was what I was asked to do. And the future is now here, actually. And I think that's why this is such an exciting time for irritable bowel syndrome. I'm going to focus on the microbiome on irritable bowel syndrome. And I think what we've learned from our patients, we focus on the Bristol stool scale. And patients with diarrhea, we try to make them constipated with our drugs. And patients with constipation, we try to make them have diarrhea with our drugs. When what we really should be doing is trying to make our diarrhea patients normal and our constipation patients normal. And so understanding the pathophysiology of IBS is the first step. And then you can try to make them normal, because if you don't treat the cause of IBS, you're simply giving a laxative or an antidiarrheal, and that's it. Now, those drugs may be inexpensive, and that's something that always factors into treatments or new treatments for IBS. But my talk is here to talk about the future. But you can't talk about the future without first talking about the past, and so I'll talk a little bit about the past. But over the last now 27 years at Cedars-Sinai, we've worked heavily to try and work out the pathophysiology of IBS, and I'm not saying the story is complete, but I'm saying many of the pieces are now starting to come together. And I've been using this slide for a number of years, but the pieces on each of the sections of this slide are more clear today than they ever have been. That at least 60% of diarrhea IBS started from food poisoning. E. coli, C. jejuni, Shigella, Salmonella, some acute event. And then ever since then, you now have irritable bowel syndrome. But we increasingly understand the role of a particular toxin called CDTB from these pathogens, leading to an autoimmunity in IBS, leading to a neuropathy, leading to a change in the microbiome. And what I'll show to you today that's very new is that the microbiome changes differently in different people in this process. And that different change results in a different phenotype, and why IBS has 3 phenotypes of constipation, diarrhea, and mixed. And then, of course, IBS is an antibiotic responsive disease. Starting in the past, I think it's without a doubt, there is no argument or discussion, or there shouldn't be an argument or discussion, that food poisoning or acute gastroenteritis precipitates IBS. This is a study from the Mayo Clinic by Clem. This is the last meta-analysis that's been published from 2017. And without a doubt, if 100 people experienced food poisoning at a wedding, then 11 would develop IBS and would suffer for an indefinite period of time with their irritable bowel syndrome. But how does that happen? Now we go even further back. We've been looking at this since 2008. And then in this old study from 2008, we wanted to develop an animal model. Why am I going back to 2008? Because this animal model now, even in the last 2 years, has yielded tremendous fruit. And we infected 33 rats on the right. We gave placebo to 33 rats on the left and waited 3 months. So they were truly post-infectious, no more Campylobacter. And then we looked at their small bowel, and the rats who received the Campylobacter developed bacterial overgrowth of their small bowel using PCR. So we were able to quantify the bacteria of the small bowel. But that's only just the beginning of the story, because the what type of overgrowth, what bugs are we talking about? How do we know what bugs they are? Because if we know what bugs they are, we will be able to better know how to treat IBS. But the model continued to show itself in that the rats, you can't ask rats questions. So you can't ask them if they're feeling bloated. You can't give them a Rome criteria questionnaire, but they did have altered stool consistency, increased stool wet weight, and increased rectal lymphocytosis, which is found in humans with post-infectious IBS. So this was the first animal model truly showing post-infectious IBS using a pathogen, Campylobacter, that is the most common pathogen causing IBS as a post-infectious event. So there are other models, but they're using parasites, which most humans don't get. So they're models, but this is the model that's more typical. Now fast forward to 2022, applying now all this evidence. I could spend probably 2 hours on the evidence on post-infectious IBS, but it really is summarized with this one paper. This is what we call applying the Bradford-Hill criteria, cause and effect. Does Campylobacter cause irritable bowel syndrome? Is there sufficient evidence in the literature to support this? And essentially, to a greater or lesser extent, the evidence is supported by the literature for all the Bradford-Hill criteria. So this is sort of like Koch's postulates, but more expansive and more clear. But how does this happen? And so this leads us to the CDTB toxin and how that develops into IBS. And we know all these pathogens, although they are different morphologically, different physiologically, they do often share this one toxin in common, the CDTB. So we then progress to, well, if CDTB is the issue, then maybe all we need to do is expose the rats to CDTB. So we gave this toxin to rats in their hind limb like a vaccine. 3 weeks later, a second shot, very similar to the COVID vaccine. So the rats never got CDTB in their gut. They got the CDTB under their skin. And so it was a vaccine. But the rats developed antibodies to CDTB, not unexpected. But it also created in the rats antibodies to themselves, to a protein called vinculin. And the particular vinculin, because there's 5 types of vinculin in the human body, the particular vinculin to which these antibodies react is important for the integrity of the nervous system of the gut. Not only did they get these antibodies, but the antibodies injected into the arm of the rats, they developed bacterial overgrowth and increased stool wet weight, and the same phenotype as if they had gotten a full Campylobacter infection. Now, in 2022, taking this to a more contemporary time period, when the rats get CDTB, and this is a really important slide because it comes to the human phenotype in a slide I'll show you in a few minutes. But the control rats, this is their microbiome of their small intestine, the orange dots. A group of rats who got CDTB, their microbiome did not change. Those are the green rats. A group of rats who got CDTB shifted their microbiome to a SIBO microbiome, but it was dominated by E. coli. E. coli is a hydrogen producer. And then another group of rats didn't get the E. coli, but rather they got an elevation of disulfovibrio, which is a hydrogen sulfide cluster. So, which disulfovibrio produces hydrogen sulfide. So even though the rats are getting SIBO, they are not all getting the same type of SIBO. And so now this breaks it down into subtypes, which I'll get to when we get to the human experiments. But to summarize this part of it in brief, you get exposed to this toxin, you form antibodies to the toxin, and this particular epitope or section of CDTB looks very similar to vinculin, and as a result, through what's called molecular mimicry, CDTB tricks you into forming antibodies to yourself. And vinculin, for your understanding, these are cells in our lab. The green is actin. The red, at the end of actin, you can see the filaments at the end. Those are vinculin-stained proteins, and they are sort of the motor at the end of actin that makes the cells stretch out and reach out to each other. And so in the context of nerves, if you can't stretch out and reach out because you don't have the vinculin, the wires don't connect and the electricity doesn't flow, and you get poor motility of the gut. But this allowed us to use these antibodies to develop a blood test for IBS, and this is the second generation blood test with improvement of understanding the two proteins, CDTB and vinculin, to allow the ELISA to work better. And anti-CDTB or anti-vinculin are extremely specific for diagnosing irritable bowel syndrome. The post-test probability of IBS versus IBD is 98% if both markers are positive, but over 80 is considered medical certainty in diagnostic testing. You may focus on specificity is more than 90%, or you may focus on sensitivity and say, well, that's a little bit low. It's not, because if you took 100 IBS patients, remember, IBS is a leftover diagnosis. About 60% of IBS came from food poisoning, DIBS. So if you pool these two, it's 56%, meaning and or. And so you're really right there. So if you knew who had food poisoning causing their IBS, and you're reaching 56% with the test for sensitivity, then you're right where you need to be. It's a perfect test for post-infectious IBS, not to diagnose all of IBS. Now we're going to move to breath testing and how this started. So remember, breath testing is an indirect measure of the microbiome. But this is where it all started, as Dr. Trentoflu explained, that in the year 2000, we began doing breath tests in IBS, and we found them to be abnormal more commonly than healthies. But now, fast forward to 2020, this meta-analysis from Australia, and you can see clearly that breath testing is more abnormal in IBS versus healthy. But breath testing in 2023 has become more complex because hydrogen producers in the gut produce their hydrogen, but hydrogen is used as fuel for methanogens in the gut to produce methane, and hydrogen sulfide producers in the gut to produce hydrogen sulfide. And you can see you use 5 hydrogens to make 1 hydrogen sulfide, 4 hydrogens to make 1 methane. So you cannot rely on the hydrogen measurements on the breath test because of the extreme stoichiometry here. You're losing 5 hydrogens to make 1 hydrogen sulfide. So if you have these other gases, the hydrogen goes down. So you have to measure all 3. And we now know that methane is associated with constipation, which I'll show you, and hydrogen sulfide is what's driving the diarrhea in IBS patients. But moving through the proof of SIBO over the years, this is a Swedish study showing that IBS patients have more bacteria by culture in their small bowel. This is, of course, probably the most important slide in the deck for 2 reasons. This is a collaboration with Greece, but the most important is that this is the one and only study that shows that 60% of IBS-D is SIBO based on culture. And so using the 10 to the 3 cutoff, which is the correct cutoff, as you will see if those of you who go to DDW this year. So this is the number, 60% of IBS is SIBO. Further collaborations with Greece showed the two bacteria. This was the early days. We weren't doing sequencing. We were doing qPCR for E. coli and Klebsiella. But in this study with our Greek collaborators, we got it right. E. coli and Klebsiella, and I'll show you how we got it right. In the last 3 years, we've been working on the Reimagine study. So the Reimagine study is every single patient who comes in for an upper endoscopy by any of the gastroenterologists at Cedars are eligible. They have to have no colonoscopy, just upper. And we collect the aspirate, biopsy, blood, and a number of biometrics on the patient. But we were able to identify what is SIBO using this Reimagine study. This is normal on the left. This is SIBO on the right. Imagine your beautiful microbiome with hundreds of different species. Now is 40% of the entire small bowel microbiome is Klebsiella and E. coli. And at DDW, which I can't show you yet because we haven't released the information for another month, it's 3 or 4 strains, not 3 or 4 species. 3 or 4 strains that encompass 40% of everything growing in the microbiome of the small bowel. In fact, in the Reimagine study, SIBO is so dramatic that there are no examples in the microbiome of the Reimagine study of 800 patients that mimics the extreme nature of SIBO. It's almost like an infection. So moving to methane, because methane is the cause of constipation, hydrogen is fueling this bug in the small bowel and colon, and methane, the higher it is, the more constipated people are. In hydrogen sulfide, we've identified a number of organisms. The two are desulfovibrio, which we mentioned earlier, and fusobacterium. Those are the two hydrogen sulfide producers, and they are associated with diarrhea. But that meant that we needed to have another breath test. So there was no prior technology for measuring hydrogen sulfide, and hydrogen sulfide is a very reactive gas, so it requires a specialized compartment or bag, not the usual bags for breath testing, that can hold hydrogen sulfide without it reacting or converting to other products over a prolonged period of time so that we can measure it. And then to test all of this and then create a new cutoff for what hydrogen sulfide looks like. But in patients with functional diarrhea, these are patients with a fair bit of diarrhea but are not IBD, the hydrogen sulfide level is higher than the constipation group or the healthy group. But how do we treat all of this? So the point of the lecture is to talk about treatment. What's the future? Well, the past is important because rifaximin we know works for IBS, but we always assumed it was the microbiome. But if you use breath testing, you can see, this is a study from 2019, in the Target 3 trial for rifaximin, 44%, you just treat everybody, 44% respond to rifaximin using the FDA endpoint. But if the breath test was negative at the beginning of the study, only 25% responded, versus if the breath test was positive. So having a positive breath test predicts your response to rifaximin, implying that having SIBO and IBS is part of the reason rifaximin works. And of course, if the rifaximin made the breath test normal, those patients, 76% of them responded by FDA endpoint. Methane is a different animal. Methanogens are not bacteria, they are archaea. We don't have antibiotics for archaea specifically designed, and they don't respond to single antibiotics. And we determined in vitro that a combination of neomycin and rifaximin was more effective. And then we tested it in this double-blind study from 2014. So if you're constipated and you have methane, it's neomycin plus rifaximin, and if you have neomycin available. Now, what to do about hydrogen sulfide? That's the future. So the future is we already have a drug in trials that can treat hydrogen and hydrogen sulfide simultaneously, but it is not bismuth. But for now, since bismuth is available, we lean on this study by Michael Levitt from 1998, and we give a combination of rifaximin and bismuth, and I will show you that at the end. This study just got published before the holidays in November in the American Journal of Gastroenterology. And again, what we're pointing out here in this study is this is an IBS-D clinical trial, an IBS-C clinical trial, and looking at methane versus in IBS-C and the gases in IBS-D. And what's important here is D patients never have methane. This is the methane level. D patients never have methane. It's always and only present in constipated patients. Hydrogen levels, you can see that in IBS-D, which is the blue line, the average IBS-D patient crosses 20 by 90, which is a positive breath test for SIBO. So the average D patient has SIBO. But you can see when the constipated patients have methane, the hydrogen's even lower than if they don't have methane, because methane eats hydrogen. And then finally, hydrogen sulfide is a D marker. So diarrhea patients have hydrogen sulfide, constipation patients do not. But what we learned, and this is the most important thing for 2023, we learned who the players are. We didn't know who the players are. So now with shotgun sequencing and deep sequencing, you'll see a paper coming out shortly in the coming weeks, and at DDW we are presenting this, but in more detail. But what we showed in this paper is that there's clusters, what we call microtypes in IBS. You have the hydrogen microtype of IBS. You have this H2S producing microtype in IBS, which is more diarrhea. And the two bugs are Fusobacterium and Desulfovibrio, and the hydrogen donors for them are E. coli and Klebsiella, which we talked about and we established with our Greek collaboration even back then. In the Methanobrevibacter, the hydrogen is not coming from E. coli and Klebsiella, rather it's coming from Ruminococcus and Christensenella, Christensennellaceae and Christensenella specifically. So we know all the characters now playing the roles on the diarrhea side for these two microtypes and the constipation side for this microtype. So we are in our lab today studying 8 new molecules that are designed. We don't have data yet. We just know they should block methane synthesis. So if we give a drug that doesn't kill the methane bug, but just blocks its synthesis, then methane goes down, constipation goes away, and your bowels become normal. That's the future. On this side, if we can block hydrogen sulfide production, the diarrhea goes away and the bowels become normal, not constipated. And so now that we know the cast of characters, drug development accelerates. But I want to point out that the consensus on breath testing and the role of bacteria in irritable bowel syndrome is now nearly global, because you have the North American consensus, the United European consensus, and more recently, just before the holidays in 2022, the Asia Pacific and Australian consensus, and they essentially agree that SIBO and IBS are interrelated, and understanding this relationship will develop the future of therapies to treat the cause of IBS, not just the symptoms. So we're back to this. There are 3 microtypes in IBS, and each produces a different phenotype. And as we saw in the rats, that's why I want to go back to the rats for just a moment. The rats getting that CDTB toxin developed diarrhea, because that's what CDTB creates, is DIBS. And they developed the same 2 microtypes as humans now are found to have, depending upon whether it's hydrogen or hydrogen sulfide. We don't know why people become methanogens, because it's not due to food poisoning, but at least we understand the microbes involved so that we can deal with them. So explaining this whole story could take about 4 or 5 hours if you went in detail, but I hope I provided some good granularity on where we're heading, where we came from, and some excitement about IBS D and C in the future in terms of development. But this is what I do. I have 3 more minutes. This is what I do in clinic now. So if I have a chronic diarrhea or a mixed diarrhea constipation patient, I now measure these antibodies in all the subjects, because if they're anti-CDTB or anti-vinculin, the patient feels relaxed and reassured that the doctor now understands why this happened to them. But the second thing is the impairment of the motor activity of the gut by the anti-vinculin means those patients with these antibodies are more likely at traveling somewhere to get food poisoning again. And I think Campylobacter, the reason it causes these antibodies is that it damages you so that you can be reinfected and spread Campylobacter through the population. And we see that with a study we did with the US military, where IBS patients have a higher chance of getting food poisoning than non-IBS patients. So knowing this gives us an opportunity to educate patients when they travel or on their food choices. We do a 3-gas breath test now. I know this is not available to you, but this is available in the US and hopefully in Europe shortly. And then if they're hydrogen positive, we give rifaximin only. If they're hydrogen sulfide, for now, we find a good result with rifaximin and bismuth. However, there are no clinical trials of that combination yet. So I caution you, this is what we do in our clinic, but we are working towards publishing data on that. And then, of course, the new drugs that are coming, that 2 new drugs. One is the one for methanogens, and the other is the one for treating hydrogen and hydrogen sulfide, which we will be in phase 2 later this year. And then in constipation, you don't need to do the blood test because the blood test is optional. It's only present, only elevated in about 25% because the cause of constipation and the methane is not food poisoning. Again, if it's methane positive, we give rifaximin plus neomycin, but metronidazole is a substitute for neomycin and works quite well. No, only anecdotal data here. There's a double-blind study with this. So in conclusion, it's exactly 25 after, so I hope I didn't rush too quickly. IBS is commonly a small bowel microbiome disease. SIBO is an important contributor. With our amazing collaboration with your country, we established E. coli and Klebsiella as the main key players, as the root, so to speak, of what's going on and the production of hydrogen that leads to all of these things. And methane is associated with constipation. Hydrogen sulfide now is increasing our understanding of how come some patients have more diarrhea. So getting rid of those, getting rid of methane, getting rid of hydrogen sulfide is the key to the future of treatment of IBS. And then autoimmunity from gastroenteritis is critical. But IBS, as Dr. Triantafylou expressed at the beginning, make these biomarkers make IBS an organic disease. It is not a functional disease in that sense. You have a biological cause of IBS, at least 60% of IBS. So while I focus on all this microbiome, I'm not really talking about all the different drugs in IBS, because I think the way my philosophy is, treat the cause, don't treat the symptom. You don't put a Band-Aid on a wound and leave it. You don't give morphine to cancer patients, you give them chemotherapy. So you don't want to cover up the symptoms, you want to treat the root cause of symptoms. And I think that's the future for IBS. So thank you.
Well, thank you, Mark. That was amazing. And allow me to share with you some of my thoughts as I was listening to your talk. You mentioned for the first time hydrogen sulfide. And the H2S can come from bacteria, but it can come also from the host. And the host H2S is considered to be anti-inflammatory. So it could even be a reaction because of the local inflammation developed in the small bowel due to overgrowth. So I would like to reverse that a bit. Could the answer to the problem, if that was the case, was to give the traditional sodium STS, which is the donor of H2S, as a treatment for these cases? What are your thoughts on that?
Yes, I mean, it's possible. There are many avenues, more avenues known to impact H2S production than there are for methane. For example, just go on a low sulfur diet, H2S will go down. What you mentioned would also might be impactful. What I can't talk about, because DDW is still a month away and I wish I could be more open, we've actually, in our humans and in the rats, and the results are very similar, we actually, from the biopsies of the duodenum in these patients with H2S or hydrogen, we look for expression markers. And we can see the changes in inflammatory markers. We can see the changes in hydrogen sulfide, human hydrogen sulfide disposition pathways being elevated because of the overabundance of hydrogen sulfide. But you're right, hydrogen sulfide has a lot of downstream effects. Hydrogen sulfide in higher amounts going through the portal system changes gluconeogenesis. It changes vascular tone. It changes. So yes, we produce our own hydrogen sulfide to facilitate those effects in the body because hydrogen sulfide is a gasotransmitter in the human body. But what it does at higher amounts, as you might expect from the gut, is supraphysiologic and detrimental, at least to the gut. We don't know outside the gut. An interesting thing, and I'm just going to toss it out there, methane slows heart rate. We just published a study that it slows heart rate down, and we know that it affects smooth muscle, and we were surprised by that. And what's another interesting thing is, as you age, you have more methane. People who live to 100, almost 80% of them are methane producers. So there's a lot of implications as to whether methane is good or bad in terms of longevity and other factors. So don't get rid of your bacteria, just modulate them.
Yes, this is quite interesting. I mean, we had the opportunity to witness a presentation that starts from the early beginning of the new era until nowadays, and we could have very well seen that how Dr. Pimentel is building the theory with the experimentation and with the animal models, and then to translate it in humans to evaluate all the pathophysiology of the development of the irritable bowel syndrome. Thus, beyond the tasks of educating physician, this presentation is a landmark about teaching on how to conduct research. So it's great privilege. So Mark, yeah, it's exciting, the new findings about the H2 sulfide and the role on the development of the IBS. But let's go back to current treatment. And unfortunately, in Europe, we don't have the rifaximin as you have in the United States. So you have to give, I mean, a package of rifaximin per day to the patients. And we also don't have the ability to measure hydrogen 2 sulfide. So what would you be the advice for your colleagues, I mean, in Europe on the further, I mean, improved treatment of the IBS?
Well, I think what I'm doing in my clinic, and this is something without breath testing you could try, for patients with who you suspect have a microbiome-associated irritable bowel syndrome. For the constipated patients, if they have bloating and constipation and you don't have breath testing, I would almost assume that it is methane at least, because you could always do anal rectal manometry. We talk about all these different other modalities of investigation of constipation, but how easy is it for 2 weeks to try rifaximin plus neomycin or rifaximin plus metronidazole? And if the patient, I had a patient in clinic just Tuesday, 80% better from rifaximin and neomycin, and he's been better for months. So, you know, that kind of response, clinical response, maybe you don't need a breath test. On the diarrhea side, we're talking about rifaximin, which is one of the safest drugs we've ever known, doesn't cause bacterial resistance. Another interesting thing is with shotgun sequencing we're now doing of the small bowel, first in the history of humanity, shotgun sequencing of the small intestine, we see penicillin resistance. We see all the resistances. We see zero rifaximin resistance after all these years. And there are no resistant genes detected in the microbiome. One interesting thing I think Evangelos will like, and I'm scared to tell him, there's penicillium fungus growing in the small bowel. What does that do to your resistance to antibiotics? So we're learning all sorts of extraordinarily weird and wonderful things that are going on in the small intestine. And so I think empiric therapy is okay, And we know rifaximin and bismuth are both relatively safe in short term.
So Dr. Rokas has a question.
So Pimentel, for this excellent presentation. In collaboration with people from Sydney, Australia, we had the opportunity to publish a network meta-analysis just a month ago in the European Journal of Gastroenterology and Hepatology. And we showed that overall fecal microbiota transplantation is not superior to placebo, but when you perform sensitivity and subgroup analysis, it seems that the delivery route is very important, which means that FMT through colonoscopy or as an enema is inactive, whereas when you deliver it by nasojejunal tube or during the duodenoscopy is effective. So since you mentioned that SIBO and IBS are interrelated, can you speculate, please? I mean, I repeat that our findings is that if you have, to do something beneficial to IBS people talking about transplantation, fecal transplantation, you have to prefer the upper GI route, which means, delivering into the small intestine. So since you mentioned this in the relationship between SIBO and IBS, please, I would like to have your speculation on that.
So what we're learning in the small bowel microbiome. So first of all, I didn't show those slides because it's just too much for 25 minutes. The small bowel microbiome is entirely and completely different from stool. There is no or very little Bacteroidetes in the small bowel. It's firmicutes, proteobacteria, and actinobacteria. You don't need to know, but in the colon, it's firmicutes and Bacteroidetes as the two dominant forms. But in the small bowel, it's a battle. It's a battle between different categories of bacteria. E. coli and Klebsiella, as they increase, they destroy the bacteria around them. We're calling that a disruptor. Interesting, one of the biggest disruptors of the small bowel microbiome is lactobacillus. It destroys the normal small bowel microbiome, which we didn't know before this. Bifido doesn't, but probiotics have lactobacillus, so it's a little concerning, but we don't know what the implications are. But it does reduce. But if you introduce Bacteroidetes, which is a stool flora, into the small bowel, could it recalibrate all the E. coli? It's not a favorable environment for E. coli and Klebsiella, and as a result, it fights back and reduces the E. coli and Klebsiella. Hard to know, but because nobody has studied the microbiome of the small bowel before and after fecal transplant. But imagine if the problem in IBS is the small bowel, then changing the stool doesn't help, right? So you're on the right track. You have to change the microbiome of the small bowel, not the stool. So I think the data are pointing in that direction.
Okay. Well, I would like to wholeheartedly thank you. I wish the best for a happy Easter, and we are looking forward to the continuation of our collaboration. Thank you so much for being with us.
Thank you. Thank you. Bye-bye.
Bye.